has been mentioned, and all of us were here last year or in March, we know that one of the key priorities for Central Region is Operation 4.4 holistic assessment. Then the other one was to also improve maternal and neonatal health. And this afternoon we've heard that our maternal mortality is gradually going down, and we pray that we'll be able to sustain it till the end of the year. Another thing that was introduced was men's health. And also we started operationalizing our staff clinic, then quality improvement in terms of our service delivery in the area review. That's we are targeting both the hospital and the health centers. Then to reduce audit infractions, then as we all know, the free primary health care implementation, monitoring and support supervision, staff training and capacity building. So with all these priorities that I mentioned, we set for the region, these are the staff strength that we're using to achieve them. You know that our staff strength is 10,313 as compared to 10,342 last year, half year, the same time. This year, our recruitment for half year was 63. The recruitment that we have for this year started in the second half, so hopefully at annual review is to increase. Promotions, we've had 726 promotions across all cadres of staff. Post and transfer, the trans-in is 89 and trans-out is 73. For staff separation, that includes the resignation, vacation of post and retirement, we've had 58 against 75 last year. Leave without pay, 34 again 51, which shows that we are trying to improve in this indicator. Then sick leave, we have 1. Conversion and upgrade, we have 203. Salary input process, 523. Then study leave. For the study leave, we have 101 people who have had admission and have completed the portal, but the 817 has been granted. So with the staff strength, if you look at it, you can see that the high numbers that we have are, let me say, the other staff. When we take medical officers, dentists, specialists, we have only 2%. Our council parents may rightly mention, we do not have a lot of specialists within the region. For pediatrics, those that we have, quite unfortunately, are in the teaching hospitals, and we have a few in the chat facilities. But when it comes to the Ghana Health Service, for instance, we don't have pediatrician, we don't have a physician. As I said, we have only one who is also in school. Surgeons, we have about 3, so we lack them. Then professional nurses, we have 23%, enrolled nurses 18, and community health nurses 13%. When you take male and female dominates, and we form about 73.5% of the total population. So vacation of post 23 against 37. Then let me come down to the death. This is quite alarming. Last year, half year, we had only 2, but this year we've had 14, which is too much of a number. And unfortunately, the data that we have, most of them are more NCDs. You get to know a stroke, is hypertension, and the other thing is that people were found dead in their rooms. And for that, we've stressed, and medical district directors have been encouraged to ensure that at least people have their medical screening done once a year before they even proceed on leave. And for that reason, we decided to set up a medical screening this morning, but unfortunately, the attendance was very low because we came in late, so we couldn't get that. So please, if not anything at all, check your BP, check your sugar frequently. You can even make it quarterly. Then for leave without pay, I think our education is going on, so the number is decreasing. Because most of the time, people will just bring in their leave. Before they even bring their leave, they are already gone. But now the education is going, so it's getting better. For retirement, we have 15, again 26 last year. So these are the key activities that we have implemented as a region. For us, transport manager and equipment manager came around, and other personnel came around to give support to the district and facilities. Asset and inventory management has also been done. Infrastructural maintenance and development, equipment management, and other administrative supportive services have been done. When it comes to infrastructures, we have a duplex PSA plant at Ankafo Hospital. Then we have a construction of liquid oxygen in trauma and specialist hospital, and also the 5 free primary health posts or kiosks, let me put it that way, has also been completed. Then we have 44 motorbikes that were distributed to selected facilities districts. Then we also received equipment for the phase 1 of the free primary health care. So for public health activities, we've done 1 round of the onco-psychiatrist MDA in 3 districts, that is AOB, Thailand, and TAM. Then also we conducted school distribution of ITM in public and private schools. We've had a catch-up TB case finding with NTP and UNICEF. Then also African Vaccination Week celebration was also done in all the 22 districts. Then currently the malaria vaccine, which is the RTSS, is now being switched to R21, and that one was started on 30th June. You know that the RTSS has both the diluent and the vaccine itself, and the R21 is just one. So in terms of cost and also space, let me put that way, that's why it has been switched to that one. Then also with the research and pilot study of multiple micronutrient supplements. And for HIV indicated, it was very low, especially those that are linked to care. And this year we're fortunate to have collaborated with other NGOs such as AIDS Commission to conduct, to strengthen the HIV program that we have. And also we've had a revised training on the health promotion register. So for the family planning, I think it was mentioned earlier, where family planning we improved a little, and now we are having family planning commodities, and our 4th ANC bases are also increasing because there is supporting supervision and because it gives it the district. But the areas that we are still struggling with is the ANC coverage, and some of the reasons are inadequate institution of pregnancy schools and home visits within the district. Then unfortunately our stillbirth is so high. And that's one, yes, there is late reporting for ANC services by pregnant women, but then people can come for ANC, but then sometimes when it gets into the 3rd trimester, they prefer to switch or they delay in seeking for care. For the percentage of 1st trimester registrants, I've mentioned that because of the monitoring. One area that we are not doing well is the under 5 mortality and inadequate newborn and child emergency care. We don't have pediatricians. The nurse specialists who go in for pediatric care are also few. Then unfortunately, poor referral system. We have only 1 teaching hospital with few NICU capacity, and now the road, as we all know, from here to Accra, even if repair case is terrible, then ambulance service is also another problem. So we are not doing well with our newborn, and then poor ANC attendance. But for the treatment success of TB is getting better, but then the notification is so low. Then when you go down, we notice that there's weak surveillance at the lower levels. And the question of what people actually attribute is that there is no fund for those monitoring. But then we want to encourage that at least we can ride on the back of other programs to ensure that we are able to do the surveillance at lower levels. So for finance activities implemented, they have done 4th quarter of 2025 and 1st quarter of 2026 financial validation exercise. They trained staff on DIMS 2 entries for finance data. And we had opportunity by the government secretariat training the facilities. But unfortunately, Ankafu Hospital, Derapa Polyclinic, and Senior Polyclinic were not on the list of their, the list that they brought were not on it. So plans have been made and they are also going to train later. Then for NHIS health facility focal persons have also been trained. Then after the training, there has been the first half NHIS supporting monitoring exercise to 39 BMCs. And for the new models, for the iPass e-transactional tool, which is for the panel data entries, and staff have also been trained on that. For clinical care, we had the CPD training for physician assistants, then maternal task force actually met at the beginning of the year to plan through what we can do to help reduce maternal and later death. And after that, we've had our safe motherhood training, which was supported by the district and the facilities. And we also had FOIPA coming in to support our safe motherhood training. We were fortunate to have specialists from psychiatric units at Kolebu to help us do 3 outreaches of specialist outreaches at TAM, AOB, and Abuna West, Swedru. Then we've had 2 nurse managers meeting. Then we also had our ANC and maternity in charges meeting, which was really, really helpful. And we are praying that all these things that we put in place for the maternal health and neonatal health will actually bring things down. So these are just indicators as a region. I think when Mr. Akofisha was present, we noticed that malaria can be straight, but then malaria consistently talks. We have malaria as the first, followed by upper respiratory tract infection and anemia. And not surprising when we're talking about anemia in pregnancy. We have rheumatism, and I wouldn't say, fortunately or unfortunately, our hypertension is coming down. If it's coming down, there are 2 questions. Are we screening? Or we are not, people have it, but they are not just reporting. Because as you all know, hypertension will not give you any signs and symptoms until complications set in. So that figure can be good or can be bad. When you take our top 10 admissions, it's still malaria, then followed by gastroenteritis, then UTI, and the last is bronchial asthma, the last is diabetes. And for that one, also tell our patients actually managing their diabetes well? Are we putting patients on the optimal treatment, or they are sick but they are not reporting, but they are rather taking help somewhere? For top 10 cause of surgical operations, cesarean sections, in the topmost we had 8,611 formats, 43.9%, suture illustrations, and wound dressing followed by hernia. So the key challenges that we have as a region, inadequate funding, then aging vehicle fleet and workshop constraint. If you are here and you have a car, you can dash the regional health. One. Yes, sometimes we know we have to have monitoring in the rest, and there's just few cars that we have lack of supply. Then high indebtedness to suppliers. So if you owe RMS and you don't pay, then definitely you also owe our suppliers. Then insufficient space at the RMS. I think most of us heard about when the flooding issues happen, we are also not spared. Then human resource gaps across technical and support groups. We lack standardized register for rampart data capture. Then data inconsistency in GIMS is a problem. Even though we do data validation, but we still have data inconsistency. Sometimes you go into it today, then this time when you even ask for changes to be done, people will go into it. What you ask them to change, they will change and bring another trouble. So please, when we are doing the data validation, let's ensure that we are able to do it and do it well. Then occasionally our gene effect machines get breakdown. Then TB screen and also transportation sometimes are not being carried out at our facilities. Our TB notification rate is very low. So if you take the samples from patients and we don't send them to where it can be tested, then it means that we are not working. That is what it means. Then I mentioned that we support the supervision to facility levels across board, and especially with vaccine. So for priorities for the second half, we are just going to follow up the priorities that are mentioned for the beginning, and maybe for a few of them, we'll concentrate on, we actually want to have a schedule project supporting supervision, then monthly data validation and feedback to districts for appropriate correction. Then for TB, because we want to increase our notification rate, we want to do quarterly community-based TB case finding, then strengthen family planning delivery through capacity building, then also enhance emergency district outbreak preparedness. This is very important because I think experienced cholera, and this year when something started, we actually got people coming in fast, and because of that, we didn't have any, I wouldn't say, they reported early, but unfortunately they were all negative. So it tells us that the awareness is there. Then quarterly financial validation exercise, internal finance review for all BNCs, then financial monitoring on program funds and IGF, training on SOP implementation for all polyclinics and hospitals. And for the health post related to the free primary health care, one of our priorities is to ensure that they have the NHIS credential. We want to acknowledge the regional director for her leadership and all SMC members, our medical suits and district directors, all our stakeholders and our staff. Thank you for your attention.
Today, Professor Reverend Chair was talking about acceleration in the morning. And for us to accelerate, we need data to accelerate. And the person going to do justice to that, he has been coming to us for years. But today we will introduce him. To do that honor is...
Thank you very much.
Yes.
I'm glad to take you through the second the program. So introducing the next speaker, please help me welcome Director Susie Bill. Please let's do it better for her as she joins us.
Thank you very much, Madam Mr. Chairman, Dr. Professor, Reverend, our mom, distinguished guests, ladies and gentlemen, good afternoon. I'm humbled to be called upon to introduce our speaker for the next presentation. He's someone that we've all heard the name one way or the other, so far as immunization is concerned in Ghana Health Service. Trust me, others haven't seen him before, it's just a name. Sit, relax, hear his bite. Break response and COVID-19 vaccination, including Ghana's historic receipt and deployment of COVID-19 vaccines through COVAX. His career spans as a district health leadership, service as a child health specialist with UNICEF Ghana, the consultancy roles with international organizations, including World Health Organization, and the Centers for Disease Control and Prevention. An academic, a contributor as a leader, and a mentor to public health professionals. He is a fellow of the Ghana College of Physicians and Surgeons. He holds medical and public health qualifications from the Kwame Nkrumah University of Science and Technology and University of Ghana, and the Galilee International Management Institute, with international training and fellowship experience as an with international training and fellowship experience, including with international training and fellowship experience as institutions including University of Cambridge, Albany College, Yale University, and Ghana Yale Partnership of Global Health. His contribution to public health and workforce development have earned him the National Honor of Companion of the Order of Volta. Lastly, he is also a wonderful indigene of Asin South. Ladies and gentlemen, welcome Dr.
Madam, you forgot to add one thing. That Dr. Chanel crawled on the streets. His blood is green. I hope you understand what it means. His blood is green, so that soon is one of you. Action. Okay, so we welcome Dr. Cheno for the second presentation on data for acceleration using these two social mapping and community feedback to track progress on UHC. Dr. Cheno.
Thank you very much. First of all, my thanks goes to Director. When she called me about this presentation, I was very hesitant because I was asking, Director, why me? Anyway, I'm here. So, and thank you for the kind words. I thought I would have needed more of the time to do my presentation than the introduction. But thank you anyway. And just as my friend and my old friend, Dr. Bento said, I'm a son of the soil. I'm from Cape Coast, I'm from Anamabo. I'm also from Asne when I was in St. Augustine's College. Thank you very much. So my task is very, very difficult. I don't know whether I'll be able to do that, but since I have only 20 minutes, let me start. I'm supposed to take you through data for acceleration using DIMS2, geospatial mapping, and community feedback to track progress on universal health coverage. When I thought through it, I decided that we would have to go through just 2 points. So my objective, and like the teacher in me, that number 1, together we will explore 3 data tools. Is anybody changing for me? Or why I can't? Or you are doing it?
Yes.
Yes, so as I was saying, together we would explore 3 data tools working together, not in isolation, to track free primary health care chips and NOPs. And then number 2, for every district, we would want to identify 1 concrete action your district will take or can take in the next quarter to strengthen the data loop. And I picked something from the Honorable Chair's remarks when he was accepting his chairmanship. So I'll start with that. We cannot improve what we cannot measure. And that's the reason for this presentation. So I'll run through this agenda, and each of them will last between 2 and 4 minutes. So I'll spend a bit of time on DIMS2 in practice, geospatial mapping, community feedback in practice. And then we'll put all the things together. So why data is the accelerator for UHC? I know you are more versed with the free primary healthcare chips and networks of practice than myself. So these 3 are strategies, the strategies that have been drummed over and over. And data is what tells us whether they are working together, where they are working, and for whom. And for us, as Central Region, in our semi-annual review, what we popularly call the half-year review, the goal has been explicit that we will strengthen free PHC, revitalize CHPS, and operationalize NOPs to improve access, quality, and financial protection. And in the concept notes that Director shared with me, data for decision making is one of the 4 cross-cutting priorities. The others are human resource and community engagement. plus others. And as we know, without integrated data, we will only manage the districts. Now I have over 500 chip zones, and the over 3 million people by impression. So we'll say, I swear God, I did it. If we do not use data. So evidence is key. So what is the canvas? This is the canvas on which we are planting our data issues. So I know we all know we have 22 districts, over 3 million people, several facilities, several chip compounds and zones. Unfortunately, as I heard from the director, only 14% of the properly demarcated are functional. And then, of course, other health facilities and the 45 or so hospitals and polyclinics. So that's the extent and the canvas on which we are setting our stage. So just a bit of recap. We all know free primary healthcare, but if you not remember anything at all, remember that free healthcare is eliminating financial barriers at the point of care. Whilst CHPS is a community level delivery backbone, which, as we have already said, is still incomplete in many parts. And the networks of practice is the one that is doing the coordination, the referral, and the resource pooling across the districts. So this is what you have already been doing, but these are the pillars on which we are going to situate work. So the UHC data ecosystem, there are 3 interconnected tools. So these are the DIMS, geospatial mapping, and community feedback. And with community feedback, because we are dealing with data, I will spend a bit of time on the community scorecard. So the DIMS will tell us what is happening in numbers, just as Mr. Kofi did. Geospatial mapping is what will tell us where the gaps are. And the community feedback will tell us the reason behind the numbers. Why? In the people's own words. And together, the full picture of UHC would have been provided. So the first tool is DIMS, and I know you use DIMS every day. Most of you are adept at it, but you cannot do this presentation without going a bit more. So Ghana's District Health Information Management System, DIMS 2, which is a national platform on which every facility reports. I'm using every advisedly because I know sometimes it's difficult for some of the privates to present, to DIMS, but I believe that in Central Region we have almost 100%. There are over 10,000 users as gleaned from CHIM. You know CHIM is the one that DIMS. And these submit monthly reports through the platform. We know it has customizable dashboards, or you can customize some dashboards that usually will let us, as region or district teams, track indicators. For example, OPD attendance, which already have been presenting, EPI, of course I cannot talk without mentioning EPI, ANC, then National Health Insurance claims, CHPS, functionality, malaria, TB, HIV, you name them, and many, many more. And for us in Central Region, DIMS 2 continues to be the system of record for whether free PHC, CHPS, and network of practice targets are actually being met. So we are situating DIMS as the first leg of the 3-legged tracking system, which I've already done. So this is just a mock-up. It's not a real data. So this is just a prototype, a view to show the kind of dashboard that you have been producing already and the kind of support that you can get from DIMS. So we can be tracking the OPDs, the CHIP zones, the CHIP zone functionality status, NHIS membership, referral completion rates for NOP, and then, of course, like we've already mentioned. And so the real dashboard, as you know, is live at CHIP, and you have access to that. So an example for us as Central Region. So normally, NHIS membership would have risen from a certain level to another level at the national level. And it is only the DIMS 2-lane claims data, which is at the district level, that is what we can use to verify the trend locally by district. And the district recording OPD attendance, for example, below 70% facility, can be flagged automatically for follow-up, so that we will not wait for the next review meeting. Again, CHIP zones functionality in terms of staffing, equipment, reporting, which Director already mentioned, can be tracked over time, showing exactly how many or which of the central regions CHIPS, whether it's 400 plus or 500 plus facilities, need support. And again, from the concept note, I picked the fact that some districts, Cape Coast, Aguna West, and Assin North, have already made some early gains on their NOPs. And these are visible first in DIMS before they can be anywhere they can. Has identified where over half of communities have strong CHIPS access and where gaps also concentrate. And for us in Central Region, mapping is what is going to turn the CHIP zones remaining complete within the concept to a precise actionable list of which zones and where are they. So again, this is another schema to show how GIS can work with this. So the pattern illustrates functional versus non-functional zones clustering within a district in real time. And this is usually recurring, it's a recurring finding from a lot of studies already taking place. So for us, another example for this is mapping underserved zones. So we can overlay the CHIP zone locations against a 3-kilometer catchment standard to identify communities currently outside effective walking access, which I mentioned for CHIP zones is 3 kilometers and for hospitals 5. We can also map referral pathways between CHIPs, health centers, and hospitals to see whether the network of practice routes match actual geography or whether patients are being forced to bypass the nearest or closer facilities. In that case, we need to investigate why this is happening. Again, districts with early NOP traction, like the district we mentioned, and it can be mapped as reference cases for districts still building their referral networks. And combined with these two, utilization data, mapping shows not just where cities are, but where they are underused relative to the population around them. So these two will show us what is happening, and then the geospatial mapping will tell us where. And when we connect that to with the two tools, then we are gradually coming to home. We are coming home. The third tool is the community feedback. In a zone. It is only the community feedback that reliably tells us whether it is access or quality issue or a cultural barrier. So community feedback is a tool that gives the other two data sources their meaning. So it's the why behind the issues. So there's a look that I would like to share. The scorecard cycle usually starts with a community data, then it feeds into a quarterly rating, then the district picks it in the reviews, then there's a community health action plan that is created from that, and then it's supposed to guide service upgrade. And then once the services, we think the services are upgraded, how do we measure it? We have to use the DIMS to measure it, and then the cycle continues. So the key point here is that it's a closed loop with a name which is mainly the community health action plan. This one survey that disappears into a report like we do. So an example given for the scorecard. So quarterly scorecard ratings are done at the CHIPS or facility level. That gives the district health management teams an early warning system, independent of whether the reporting is good or not. And recurrent themes in the scorecard is used as a feedback, and usually it is transport, cost, staff shortages, commodity stockouts, and others. And these map directly to what the regional director raised as the issues around CHPS implementation challenges. And the community health action plans created from the scorecard results give us the MMDAs and the traditional authorities a concrete community-owned action list, which is co-owned and co-funded for monitoring. When we aggregate this across all our districts, the scorecard will help us. The teams within the scorecard, when triangulated with the other tools I mentioned, things and the spatial mapping, the region can use it as a priority tool. Now let's connect all of them, connecting the dots. So we'll start with the things, flagging it, like it was mentioned, like let's say low ANC or low EPI or low pentafluoride coverage. So low ANC fault visit coverage reported in the district. Then the mapping will locate it. The spatial mapping will show us the CHPS zones beyond 3-kilometer walking distance, which gives us an idea of the access issue. And then community will confirm it using the community scorecard. So the scorecard will cite transport costs and staff absence or access barriers as an example. Then the NOP CHPS, and then of course the PHC will act on it. So the district team deploys outreach and referral links to nearest facilities. And then back to DIMS. DIMS will remeasure it. So DIMS will remeasure it in the next quarter's, whether the next quarter's ANC has gone on. I cannot talk about this without mentioning AI. Because just last week we had a meeting at the ministry level. The ministry has developed a new AI policy. And whether we like it or not, we use AI. Yes. So I slotted in this. So AI can be used to automate some of the anomaly detection spots without necessarily having people sitting behind it. You can set it as an automatic thing. Then again, AI can help with the mapping by using predictive models, rank the best sites for the CHPS to cite a CHPS compound or to cite a CHPS zone. And then, of course, we can also use that to estimate populations that are left outside the 3-kilometer regions that I mentioned. And then finally, for the feedback, the community scorecard, which usually is one underutilized, mainly the one that suffers if there are funding challenges. You can use AI or large language, bring all the things together within seconds, and you may not need to sit behind that machine for a long time. So I drew a few recommendations for director and your team. Number one, let's institutionalize the 3-tool loop. So this one will require the DIMS tool, that's the flagging, then of course the mapping and the scorecard teams. That should be reviewed together at every district review and not separately. We should also build, I know we've built a lot of capacity on GIS, but we can expand that capacity at the district level. And within the DIMS, there's I'm sure many of you know that there's a module for GIS, and that alone can close most of the gaps. We should also protect the community scorecard quarterly operational rhythm. It's supposed to be used quarterly. And it's the most under-resourced, as I said, of the 3 tools, and the one that is most easily dropped under pressure. I would also suggest that we nominate a data integration focal person per district to triangulate the DIMS tool. I know that HIs can do that, but if you have young guys who are very interested, who show interest, I think you can give that assignment to them so that they can use that and the scorecard findings usually prepared ahead of the meetings, the reviews. And then finally, feed triangulated findings directly into the 3 policy recommendations that the region has indicated it will submit to the headquarters and update it regularly. Distinguished ladies and gentlemen, before I sit down, our key takeaways are that 1, DIMS 2, those spatial mapping and community feedback are not 3 separate systems. They are one tracking tool with 3 different entry points. The second issue is that for all our districts and over 500 chip zones and over 3 million people, these are exactly the scale where this integration pays off fastest. And number two, the technology exists and is already in use. We know they are all used. The accelerator is discipline. It's a discipline in using all together every review cycle. And finally, data for acceleration means turning free PHC, chips, and NOPs from policy recommendations or commitments into measurable tracked progress. Before I sit, I remember somebody defined a consultant as the person who doesn't have a watch, but looks on your watch and tells you what time it is. And I hope I've done that. Thank you very much.
Thank you very much. You can do it better for Dr. Achebe. Over to you, Chair.
Thank you. Thank you very much. I think we'll take questions for about maybe 5 minutes. Next 5 minutes, let's take some questions. Dr. and then Dr. Amponsa. Any questions, clarification?
Thank you. My question goes to Dr. Anani. I want to know the reason behind the outreach that the mental psychiatric, what influence informed the office to do that particular outreach. Did it include the staff or it was only for the team? I want to know what, because that area is becoming a big problem. And what that particular district.
Dr. Kwao.
Thank you, Dr. Nani and Dr. Achebe for the great presentations. My comment question is to Dr. Achebe concerning the community score. It's as he pointed out, I believe it's a vital gap in the current data collection, that we use it to assess the primary health care. And when I look at CHPS, CHPS is community-based health planning and services. And maybe he can give us more on how that health planning bit is supposed to be going on. I also want to know how this system, beyond the district level, at the community level, how the community health management committee would function. Because I believe that in the original iteration of the CHPS, there was supposed to be a CHPS, which then helps with the health action plan at the community level. So how would he suggest that we incorporate, because it can happen at a district level, but then I think there's a gap at the community level too. And maybe, as he said, it's because of under-resource. But how would he suggest that we go forward?
No, thank you. Thank you. Any more questions? There's a hand up here, front row. Any more questions apart from Director?
Yes, so Chairman and Director, good afternoon. So mine goes to Dr. Anani. Yes, so with regards to the training that the NHIs gave, I don't know what the challenge was, but I will want to find out what the needed impact was made on the training. What was the challenge? What was it meant to address? Was it able to have it addressed? The issue of adjustment in the central region is very high. I was at Upper Lintra West, and then you can see that most of the facilities have high level of adjustment. Especially, there was another two, the presentation actually all the districts across, and then when you go to the Kaswan area, we have about 17% adjustment on the claims that you submit. And I think that is not too good. In the region, we are doing something around 8 as an average. And I don't know whether that wasn't a challenge enough. And are you not losing any money? And how are you able to get that money back? Are you getting it from my insured client? That is why you are so comfortable, because you lose it through the left hand and you can get it with the right hand. I want to, because beginning of the year, in most of our meetings, we are trying to get it down to about 2%. So for the rest of the year, myself and director, that will be one of the core issues that we want to deal with, especially with the team accelerating to achieve universal coverage and the free primary healthcare. Thank you very much.
Okay, thank you, Dr. Coy Thompson. I hope I had enumerated. There are no more questions there. That was very fine. So I think the two presenters will please respond.
Thank you very much. So, Father, as I said, we lack specialists within the region, and apart from our full psychiatric hospital where we have psychiatrists, when you go down there, we have any psychiatrists, though we have mental health nurses. So they see patients, but then we collaborated with Anchor Psychiatric Hospital. So at least the patient that they see, if not anything at all, they can have a doctor also seeing that patient, hopefully once in a year. So per the number that we have, we try to implement it during the mental health month, that's in May. So sometimes, last we were able to get some people from Colombo Teaching was joining Anchor, then we roll this out, that's the size up. So it's something that we do yearly, based on the number of specialists that we have. And also it has to be supported by the district, because if you have to move the specialists to the district, they have some financial commitments to make. Thank you. Then for the second question, the impact, yes, there is a good impact, even though the figure that you spoke about is high, but from memory, I think it's becoming better. With the claims rejection and because of the claim rate and all those things, it's becoming better. But then we've had a good impact. I wish the NHIS local person was here to give that proper feedback to you, but then there's been a good impact. Thank you.
All right. Dr. General.
I think I dreamt that Kappa will ask that question. So I brought a chief expert with me who wants to respond.
Thank you. So, the health system is divided into two. The ones we go to them and the ones they come to us. So this is the health system. So the issue with the ones we go to them is where we form the community health management committees, and they between us and the community, so that when we are going to them, it's easy to get to them. So what happens is that with the scorecard, they come to assess our system to see whether our system is serving them. Because from what you heard from Director Belinda, he was saying that the health system is designed to serve them. But what happens now, from what I see, is that people say, as for me, I go from 8 to 5. So if you say you go from 8 to 5, and I'm coming to the planning, you go from 8 to 5, but the community comes home at 4. Then the question is that, so sometimes when they go and I come to meetings, then I hear people say, patient is low because we didn't get it. But we knew they wouldn't be there. But we went anyway. And you get the point. So when we went, then we realized that they usually come from farm from 4 or fishing from 4 to 5. So they are saying that if you're going to plan with them, then instead of coming to work and sitting in that community till 4 and close, then rather plan with them, come at 3, organize, meet them till maybe 6, and then you can get your immunization done. And that's where the planning, community health planning comes in. Now when it comes to that health committee, in their scorecard, they have concepts that they think is quality. So whilst we think maybe dressing like Dr. Eve is quality, they think that a smile is quality. So you may know the names, Atesonate and Modaki, whatever names that you have. They don't know the drug names. But they look at the person who gave them the drug, and the frown on the face shows them that this drug is bad. Okay. So when they go home and they get abdominal pain, they know that it came from that frown who gave the drug and then the abdominal pain. And that's why they wouldn't come to you again and they go to the physician. So when we get those colors and they say red here or something there, then we are going to work out. And if you take the injections, when we wanted to bring injections down, they thought hospital was injection. You can't go there and they don't give you an injection. Quality is low. So we have to work through the community health management committees and work with them and convince them that even if we give you a tablet, it's still okay. And that's why I've come, we've been able to bring it down gradually. So this is what we do. So when we finish, then we do the community health planning concepts. Because sometimes they think if the place is dirty, then they cannot manage my child. And their quality indicator is the dirt around the place. So once they think that is a quality indicator, we have to clean the place to assure them that the antecedent of the acne is clean enough. And so that's the kind of interaction and the planning that we have to do. Thank you.
Thank you very much. I think okay, it looks like there's a bit of twist here. Remember, there's a Reverend Father here, so we want an honest confession. For want of time, we hear lunch is ready, and there's fufu there. So we want to know, if you go and eat her, will you come back? You will come back? Or will she continue? Come back. Hold on. Are we continuing or she go and come back? Will she continue? No. So the continuous have it all? Yes. No. Yes, Director.
If we continue, quite a large number of food will get spoiled and then there will be shortage.
So that's the problem. The food might go bad.
During the main review.
So we are praying, not that we are begging you. Let's just quickly go and then come back. And then we'll finish.
So please, let's hold on, please.
Carry on, quick lunch, carry on.
There is a bit of twist to our lunch. So please, as we descend, let's kindly take our seats. The servers will come and serve us, as in table by table. So we are not doing coupons for lunch. We sit. The place has been designed nicely for us, so we sit and then
we are coming back at 5 minutes after 4. 30 minutes break.
Thank you very much. Bon appetit.